First, I want to thank you for the invitation. It's a pleasure to be here. Great to see old friends. I'm thrilled about what you're doing with the Step Ahead Foundation. One is the Choice Project, which I'm going to tell you about tonight, we think is a new paradigm. We think it's sort of game-changing here in the U.S. We think we finally can probably reduce unintended pregnancies, and I'll tell you how. And we think programs like a Step Ahead Foundation is really the next step for the Choice Project and for health care for women, because we believe so strongly and passionately about the issues of family planning. And I'll speak to you tonight both as a OBGYN with training in public health and family planning, and also as a father of 4, 2 older boys and 2 teenage girls. And nothing makes me sweat more than my 15-year-old dating an 18-year-old, and my 15-year-old looks like she's 23. So if you want to hear about family planning concerns, you can just ask me personally how you approach that, and I may touch on that tonight. So first, I should tell you that when we did the Choice Project, we had no funding from pharmaceutical companies, but I have to say, since the Choice Project's results have come out, I am helping and accepting research funding from Bayer, Merck, and I'm also on the advisory board for Teva, and these are really the makers of the 3 big long-acting methods, and I'm happy to help them because I believe passionately about long-acting methods. So first, I'm going to start with talking about the public health importance of unintended pregnancy, and it's not just Memphis, it's not just St. Louis, it's really a countrywide problem, which we'll touch on. The role of long-acting methods, long-acting reversible methods, and why I think these should be first line. Happy to hear about others who believe the same passion, especially even in young women and nulliparous women. I'm going to tell you a lot about the Choice Project because I think it's very relevant for what you're about to do. And I encourage anyone to search or Google the Choice Project in St. Louis. You'll find some very interesting stuff there, including some patient accounts, patient vignettes, where you hear from the patients involved in the Choice Project and why free or no-cost contraception was such a game changer for them, how it's changed their lives. And I think the take-home message is really that we need a paradigm shift. When I was a resident at Pennsylvania Hospital in St. Louis, a woman came in for contraception, birth control pills. It was just a knee-jerk reaction for almost all young women. We need to change that, and you'll see why, I hope tonight, why I think we need to first offer long-acting methods. And if those are not acceptable, then consider other methods. So the bottom line take-home messages for the talk, and you'll hear them again at the end, are LARC methods, long-acting reversible contraception, are the most effective methods because they're not dependent on compliance or adherence. Very effective. We think the Choice model, or any model like a Step Ahead, any model that gives no-cost contraception is the way to go. It's a model for how healthcare should be in the U.S., and I'll tell you why. The Choice model is also important because not all methods are the same. I was in clinic the other day and a nurse practitioner said to the student said to her, what method should we offer to patients first, or should we offer all methods like on a menu? And I was very interested to hear what the nurse practitioner would say, and she said she believes strongly that all methods should be offered on equal par. And I was sitting there just typing on the computer, and she gave her spiel about why. And then she said, turned to me, she saw me sitting there and said, well, Dr. Piper, do you agree? I said, no, not at all. I don't think they're all the same. If we had a drug for cancer or hypertension that was 20-fold better than the next drug, would you offer the 20-fold less effective drug at the same time? No way. So I corrected her. I felt a little bad, but that's how I felt, and I'm passionate about it. And I also think no-cost contraception is cost savings. People always think, how are we going to pay for all these methods? And yes, with all the barriers we have in the U.S. in terms of health care and getting the methods and getting them in clinics and getting them in postpartum women, we have lots of barriers. But when you have something like the Choice Project or a foundation like a Step Ahead where you can offer them free of charge, that's how you'll reduce unintended pregnancies and save money. We already spend $11 billion a year on unintended pregnancies. So let me give you what I think is the bottom line about Choice. We'll see if this works. My colleagues in the back, and this is a little video to start. Thanks.
Women have many paths available to them. how far to pursue an education, what career to choose, how to save or spend money, whether or not to marry. But an unplanned pregnancy can cut off those pathways. Unintended pregnancy affects women and men of all ages and income levels. Teen mothers are less likely to complete their education and tend to end up or stay in poverty. Women may have to put their careers on hold. Families suffer financially, and unplanned babies are more likely to have low birth weight and other health issues that can affect them their whole lives. Unintended pregnancy has national consequences. Half of all pregnancies in the United States are unplanned. That's 3 million unplanned pregnancies a year. And U.S. taxpayers currently pay $11 billion annually to cover unplanned births. But not all unplanned pregnancies are followed by birth. More than 40% end in abortion. That equals 1.2 million abortions in the United States every year. Why do we have this problem when birth control is available? Some women don't have health insurance or have plans that won't cover birth control. Some must weigh the monthly expense against college textbooks or even against the electric bill. Other women don't follow the rigid schedules required by the pill, patch, and ring. In the real world, these methods have a 9% failure rate, and for women under 21, the risk doubles. If we all have a shared goal of reducing unplanned pregnancy and abortion, it's time to look at what really works. Long-acting reversible contraception, otherwise known as LARC, is safe, easy to use, and highly effective. LARC methods include IUDs and subdermal implants. Because they don't require anything of the user, such as taking a pill at the same time every day, LARC methods have an extremely low failure rate, less than 1% of users. In real-world tests, LARC methods were 20 times more effective than the pill, patch, and ring, but fewer than 10% of American women actually use them. Why is that? While some women can't afford the initial cost, most women simply don't know about LARC methods. Often, healthcare providers just offer the pill, which cuts off a woman's options. She can't take a path if she doesn't know it's there. Things could be different if more women were aware of LARC methods. The Contraceptive Choice Project in St. Louis provided 9,256 female participants with education and access to all birth control methods at no cost. Without knowledge or cost barriers, 75% of Choice participants chose LARC methods. And because the majority of women in Choice use the most effective methods, their unplanned pregnancy rate was only 35 per 1,000 women. Compare that to the national rate of 52 per 1,000 women. And remember those 1.2 million abortions? That's the same as the national rate of 20 per 1,000 women. Choice participants had an abortion rate of only 6 per 1,000 women. If women nationwide had access to LARC methods, we could potentially prevent up to 1,060,370 unplanned pregnancies and 873,250 abortions every year. If we're serious about reducing unintended pregnancy and abortion, we need to be serious about doing what's been proven to work. Women need education about LARC methods, access to the birth control method that works best for them, and a way to get contraception at an affordable cost. Who knows what could happen when those pathways to education, work, and financial stability stay open? The possibilities are endless. You can help women stay on the path they've chosen. Please, pass this video on.
Well, I encourage you to visit the Choice website and see not only that video, but a couple others which really tell the patient's stories, which I think are very powerful. So just taking a step back, we recognize that this is a major problem in the U.S., unintended pregnancies. 50% of the pregnancies in the U.S. are unintended, and approximately half of those end in abortion. And the high risk, and the other pregnancies that are carried to term are higher risk pregnancies. And this, the concept of no-cost contraception, is probably the first time that I think we're actually going to see a reduction in this number. This is a report from the Institute of Medicine, which is probably the most academic and most esteemed societies in medicine in terms of what's the current evidence? And they looked at unintended pregnancies years ago and recognized the problems associated with unintended pregnancies. And you know the problems. It's women can't finish their education. They can't get the career they desire. It really changes their lives. So yeah, I was scared when my 15-year-old is dating the 18-year-old rock musician. Yeah, I was scared. So what was my instinctual reaction? What do you think? LARC. No, go to my wife and ask her to talk to Allison. But she's a rather conservative Midwesterner, and she was dragging her feet. So what do? Up to her room, let's talk. So we talked, and I think that's probably one of the most important things, is to talk to our young people as parents. Probably it has to start not in school, but from parents. And it's an uncomfortable conversation at age 15, at least for me it was. But honestly, I was worried. So I said, if you ever need to come to me, please feel free. I'm happy to talk to you about this. Now, I didn't anticipate that would occur next week. That's what worried me. So then my first reaction is, no, I don't want to put my daughter on the pill. I want to put her on a long-acting method, a method she doesn't have to worry about taking a pill every day. Because I'm scared, because people do fail that use the pill. Not all. Many are great pill takers. So I'm not here to bash the pill. But in terms of unintended pregnancies, major public health problem, and we can do something about it now. So why are there so many unintended pregnancies in the U.S.? And I think a lot depends on the contraceptive methods we choose, how we teach our young people, and how we talk about sex with young people. It's interesting, there's major differences between the U.S. and many other countries, and we'll talk about that. So let's just first focus on teen pregnancy. And I told you I have 2 teenage girls, so I'm sweating just thinking about this topic. So let's just look here at the U.S. and compare the U.S. to Sweden. These are the rates of pregnancy, birth, and abortion in the U.S. compared to many other countries. And just look here at the U.S., and you can see here births and abortions compared to much fewer numbers here for births and abortions in Sweden. And what are the major differences? Is it sexual activity? Do we think our teens are more sexually active than girls in Sweden? And I would say just compare again the U.S. and Sweden, and this is the percent of women aged 20 to 24 that initiated sexual activity at different ages, by age 15, 18, or 20. And what you see here is the graphs are just about identical. So it's not that our teens are starting to have sex early or they're more promiscuous or anything. What do you think the difference is? It's not sexual activity. What do you think it is? Access to birth control? Knowledge. I like that one. How do they get the knowledge? Education? Parents, maybe? So it's different in other countries. In other countries, it's assumed in Sweden that young women become sexually active, but we have a hang-up in the United States. We have to say no. Just don't do it, right? That works, right? Just don't do it. Do you think it works? No way. Okay, I can tell you it doesn't work. So there's clear and unambiguous prevention messages in other countries like Sweden. Not that they won't have sex, but they will delay childbearing. That's the big thing that's taboo, that's not allowed. You can't have a kid this early, basically, is what they say, or they expect it will be delayed until adulthood. And access, greater access to reproductive health services. You can go in anywhere, you can get what you need, and you don't have to worry about paying for it. It's covered by the government. Comprehensive sex education. I think we're living in a dream world if we're going to think that we can teach young women just about abstinence. It's crazy, you know. I think we need to teach about abstinence and contraception, absolutely. So what's the push in the Choice Project? And in fact, let me tell you a little bit about how we got started. It's actually funded by a foundation. And I used to have to say it's an anonymous foundation. I can't tell you, but now it's in the New England Journal, so the world knows. The Susan Thompson Buffett Foundation. They are committed to family planning. They're committed to reducing unintended pregnancies. So they came to us in St. Louis and they said, Dr. Pipert, I'd like you to design a study. We want you to promote these long-acting methods, and we want to see if you can make a difference in terms of unintended pregnancies. So I wanted to design a nationwide study, but they said, no, we want you to do it in St. Louis. And we'll talk about why when I tell you more about the project. But why were they promoting these long-acting methods? And this is the main reason. These methods, the 2 IUDs and the implant, are as effective as tubal sterilization. They're really as effective as getting your tubes tied, but they're reversible. You don't worry about patient compliance, and that's the big deal. They're forgettable. How many people who have been put on a week or 10 days or 14 days of a pill forget? We all do, right? We all do. Taking a vitamin, whatever. We all forget our pills. When you miss a pill at a key time in the menstrual cycle in your birth control pill cycle, what results is a pregnancy. So we need methods that are forgettable. So here are the 3 methods that we were going to focus on, and many of you are very familiar with these methods. One is a hormonal IUD, the Mirena or levonorgestrel IUD. The other is the copper IUD, and the other is the subdermal implant. They're all extremely effective, 99% effective. They work slightly differently. The 2 IUDs basically prevent fertilization as the primary mechanism. The hormonal IUD is good for 5 years, copper IUD for 10 years, and the implant for 3 years. We're actually doing some studies now to look to see if they're actually good and effective for longer. But I'll be happy to tell you that. Tell you about that later. That's off-label use. But these methods are extremely effective, and we think these should be first line. The problem is, and this is an old data, but it's still true today, that in North America and in the US, our rate or use of IUDs is far below other countries, and we need to change that. There are many myths about the IUDs, and I'm sure you've all heard them. Myths that make providers unduly restrictive of who will get an IUD. There is misinformation of patients and providers. Patients are worried, how will this affect me? Will this cause pelvic pain? Will it cause cancer? Things like that. I'll tell you about some of those myths. The most educated consumers are female OBGYN physicians, maybe pediatric and adolescent female specialists also, maybe the most educated consumers also. But you'll see, if you did a survey, you'd find among our residents, my guess is it could be as high as 50% or more are using long-acting methods. They recognize how good these methods are, and the general population, the use rate is still quite low. Not that low, but quite low. For a large period of time, or a long period of time, there were not trained providers to put in the IUD. After the Dalcon Shield fell out of favor, IUDs pretty much came off the market. No one was putting in IUDs. They weren't available, so a whole generation of providers were not trained. There was lots of negative publicity, I'll tell you about that, and misconceptions, fear of litigation, and also we worry about, of course, the upfront cost of these methods. However, these long-acting methods are the most cost-effective methods over time. The most cost-effective. We can talk about that also. There's a general lack of awareness of these methods. Many women are just not aware of them, and I think we need to educate them. IUDs especially, and the implant, have very high satisfaction rates. There's rapid return to fertility, another concern with the IUD. They're safe, immediately effective, offer long-term protection, and, as I said, highly effective. IUDs have been around for a long time, and right now we have a 3rd IUD on the market, which I won't cover very much tonight, but would happy to take any question at the end, because we didn't use it in choice, and that's the new Skyla IUD. So what are some of the myths associated with the IUD? And this I've heard from many patients and even providers. The IUD will increase my risk of infection, or the IUD will reduce my chance of having children later on, or my doctor will not put one on. He's worried about causing infertility or causing infection, or even that it would cause excruciating pain, which I think is also a myth. And some of these myths started with this old IUD, the Dalcon Shield, which had some design defects, and there were some defects in terms of who we put this IUD in, who received this IUD. As a result, the IUD caused a number of infections, it did some harm, and was pulled off the market after a relatively short period of time on the market. So the Dalcon Shield is somewhat responsible for the bad reputation that IUDs have. The worry is that the IUD will actually drag up microorganisms and bacteria and cause infection, but it's really not true. In fact, when you look at the data, the incidence of PID, or pelvic inflammatory disease, is really very, very similar to the general population. The risk is only increased right around the time of insertion, and that's why it's important to use careful sterile technique when putting in the IUD. Pre-existing sexually transmitted infection like chlamydia or gonorrhea is probably the major risk factor for PID, not the IUD itself. So if you put in a speculum and you see mucopurulent cervicitis or evidence that you think there might be a GC or chlamydial infection, hold off and wait. That doesn't mean you can't put an IUD in women that don't have those signs. You don't have to wait for the STD to come back, the STD test to come back. You can do the test and put the IUD in and treat them if they're positive. We can come back to that if you like. I'll show you a picture of mucopus a little later. So it's just the increased risk of PID is just around the time of insertion, just the first 20 or 21 days around the time of insertion. This study was done a while back by a guy named David Eubacher, a friend of mine, who actually looked at the IUD in relation to infertility. And his theory, his hypothesis, was it really wasn't the IUD that was related to infertility. It's the infections that women have had in the past that cause infertility. And what he did, this number 1 implies no increased risk. He looked at what's called the odds ratio, or how much of an association there is between the IUD and infertility, and he found no relationship. But this was chlamydial infection. This study proved for the first time that it's not the IUD, but chlamydia that causes infertility. And I think now we know also that it's more the microorganisms, not the IUD itself, that result in infertility. If you look to see how quickly do women get pregnant after the IUD is removed, and I just reviewed another article today to look at this, an article from China, and found the same thing. Fertility returns very rapidly, and within a relatively short period of time, women using the IUD get pregnant within a very quick period of time, similar to other contraceptive methods, the birth control pill, the diaphragm, other methods. The curves are the same. So the concern about infertility is really not evidence-based. Another concern that women sometimes have is about ectopic pregnancy, or pregnancy in the tubes. But actually, the IUD prevents ectopic pregnancy. It's a powerful preventer of any pregnancy, so it will prevent an ectopic pregnancy. The catch is, for the residents and students or learners here, is that if a woman becomes pregnant with an IUD in place, there's a higher likelihood it's in the tube, so you must do an ultrasound to confirm the location. But powerful protection, reduced risk, any number below 1.0 is a reduced risk compared to no method of contraception. This is the ectopic rate per 100,000 women. So who are poor IUD candidates? And when you look down the list, there's not that many women that fit these criteria. There's not that many women. Certainly you're not going to put an IUD in someone where you suspect a pregnancy. If they have endometrial or cervical cancer, fibroids that interfere with insertion, undiagnosed uterine bleeding, that might be something you want to work up or evaluate first before putting the IUD in. But the one we commonly see among young women, especially in high-risk populations, is if you see mucopus. You open up the speculum and there's pus, yellow discharge at the cervical os. Hold off on putting the IUD in that day. Test them for STDs, have them come back in 4 to 6 weeks. I'd rather you not put an IUD through an infected cervix. The other time that IUDs can be inserted that it's underutilized is immediately postpartum. It's something that we don't do a lot of in the US, but I think in other countries are doing this, and I think we can catch up. And that's to put in an IUD immediately postpartum, right after a vaginal delivery or right after a C-section. The risks associated with that are very low. There's very low risks of increased bleeding, low risks of perforation. There is an increased risk of expulsion where the IUD will come out on its own, but still it's probably better to do an immediate postpartum insertion than have people come back, because many women will not come back for that visit. So we've seen that over and over again. When I first came to St. Louis, I came from New England, Brown University. I accepted a position as the medical director of Planned Parenthood, and I was surprised that we weren't putting in IUDs immediately after an abortion procedure. It seemed like the perfect time to put in an IUD. 1, you're pretty sure the woman's not pregnant. 2, the cervical os is open. 3, they're very motivated. Women who have an unintended pregnancy are often very motivated. So we wanted to do that, and we started doing post-abortal IUD insertions. It's a great time. Convenient, high motivation, and you can be sure they're not pregnant. And the complication rates really don't differ in the post-abortal period of time. Same-day insertion, I think, is very key. And even for the Choice Project, it's something we did and I hope you can do in the Step Ahead Foundation, is break down the barriers to getting the method that day. Don't make them come back for 2, 3, or 4 visits. See if they can get it that day. Be staffed and ready to put in long-acting methods. We actually have, this is an aside, but we have this new idea. How many people have been to the Apple store? A few Apple people out there. You know how nice it is when you go to the Apple store? You sort of walk in and someone greets you, they take your name. Well, we have this image of a store called Icon for contraceptive, like iPhone, Icon, where women just go there to get their LARC method. And someone meets you at the door and says, so what LARC method are you interested in? And then we are ready to just put in their LARC method that day. That's our dream. But anyway, maybe a Step Ahead Foundation will be doing that. What about adolescents? I've already told you about mine. Certainly they've made me sweat, but I'm very much an advocate of LARC methods for all teens, including my own. But we must counsel young women about using condoms also. Women under 25 are the highest risk group for STDs. We can't forget that IUDs do not prevent STDs, neither do birth control pills or Depo-Provera, so barrier methods are still very important for prevention of STDs. There are non-contraceptive health benefits to some of the IUDs, and people sometimes don't realize this. Protection against endometrial cancer, for example. Both the Mirena and the copper IUD protect. Alternative to hysterectomy. The Mirena or levonorgestrel IUD reduces bleeding, reduces cramping. It can be an alternative to hysterectomy in women with heavy flow. Treatment of heavy bleeding or cramping. It's the one screening question I always ask in a woman who's coming in, says, I'd like an IUD today. The first thing I ask them is, tell me about your menses. Do you have very heavy flow? Do you have bad menstrual cramps? Those 2 questions help me steer them to what I think is the better method for them. Someone with heavy bleeding, bad menstrual cramps should use a hormonal IUD. It helps with both of those. So before we started the Choice Project, we did a survey of a large number of women in the St. Louis area and asked them a couple questions. One, were they aware of the IUD and do they think it's safe? 50% of the women felt the IUD was safe. And you could look at that, well, that's good. That means there's 50% that say it's either not safe or they don't know. What were the common safety concerns? We were actually very surprised. Pelvic pain, and I told you the levonorgestrel intrauterine device reduces pelvic pain. Infertility, no evidence for that. Cancer, and that's interesting because the IUD reduces the risk of endometrial cancer. And STDs. The IUD doesn't increase your risk of STDs. A man with an STD increases your risk of an STD. 61% underestimate how effective these methods are. And this is interesting. I think I have a slide of that, maybe a little later, but women tend to overestimate the effectiveness of the birth control pill and underestimate the effectiveness of LARC methods. So back to the IUD and the myths. IUDs do not cause pelvic infection. They do not cause an abortion. Their primary mechanism of action is to stop fertilization. They do not decrease the likelihood of future pregnancies. They do not increase the risk of ectopic pregnancies, and they do not cause cancer. They may prevent endometrial cancer, and there's some data they may even prevent cervical cancer. So that's important from the standpoint of women's health. A little bit about Implanon, I think now Nexplanon. The subdermal implant is a very important method, especially in young women who may want to avoid a pelvic exam or avoid an invasive procedure. So this method, which has been approved for a number of years and has been used in many countries around the world, is very simple to insert. You still must go through a training session that is approved by the company, and it's very easy to use, forgettable method, and extremely effective. So Nexplanon is simply the same as Implanon. It's a subdermal implant that has a hormone, very low level of progestin, etonogestrel. It delivers it at a very low rate, and the rate of decline is very slow over the last 2 years, but it's still highly effective. The only difference is Nexplanon has some barium, so you can see it if you take an X-ray. So that's a very important advantage. Primarily, it works by inhibiting ovulation. When we first heard about Implanon and Nexplanon, the subdermal implant, people were worried about, is it enough hormone in large women? The results of the studies that looked at Implanon only focused on women that were either thin or not greater than 130% of ideal body weight. So there was a worry whether it would work in larger women. We know that it's extremely effective, a low failure rate, less than 1%. But as I said, this question about larger women was raised, and some people even asked when I would give a talk about Implanon, should we put in 2? Would that be better? So actually, I'm going to give you a sneak preview of one of the results from the CHOICE project. And what we did was we looked at 1,200 implant users in the CHOICE project, and we do have some large women in St. Louis. About 35% were obese, 28% were overweight. The failure rate in all groups was essentially 0. We had 1 pregnancy occur. It was in a woman who we believe didn't take her birth control pills regularly before the implant was put in, and we had a pregnancy in the first month of implant use, probably from missed pills. But any pregnancy that occurs while you're using an implant must count against the implant. So we didn't see any difference based on body weight, so we feel very comfortable that the implant is an excellent method for all women of all sizes. Very few contraindications to the implant, known or suspected pregnancy. I don't believe in this contraindication listed on the package insert about thrombotic disease. I don't think it's a major factor. Abnormal uterine bleeding in an older woman should be worked up. Known or suspected history of breast cancer or any allergic reaction to a component of the implant. The main concern with implant use, irregular bleeding. That is the main concern, and we should tell all of our patients about it before they get the implant. We shouldn't just put implants in young women without telling them. Many women, and you'll see here about 1/3, will have infrequent but irregular bleeding. About 20% will be amenorrheic, will stop having periods. About 20% will have prolonged bleeding. They need to understand this bleeding is unpredictable. So that's important. It is the leading reason why women get the implant removed. So impossible to predict, and patients must be willing to accept that before you put the implant in. So here's the data of all the discontinuations, not from our study, but in other clinical studies. Most discontinuations are due to irregular bleeding. Interesting, the next one that comes along is weight gain. How many people have experienced this in your practice? You know, where you have patients come in. We actually have seen this too, but we would say it's extremely variable. We had patients lose 30 pounds in a year, and women gain 40 to 50 pounds. It's very variable, and I'm really convinced it has very little to do with the low dose of the hormone that's released. Shift gears now. Let's talk about the CHOICE project and our results. So I told you how we were introduced to this concept of long-acting methods. We knew these methods, the IUDs and implants, were more effective methods, but we were approached by a foundation and asked to do a large study. I really didn't have any idea of the scope of the study, how big to make the study, so I asked the foundation for guidance, and honestly what they said to me was, think big. So we decided to design a study of 10,000 women. We thought that would be enough patients, enough teenagers, that we could see an impact in unintended pregnancy in our region, and we'll see what it showed. Our goals were to encourage the use of the best methods. And the way we did that, very simply, is everyone that called about this project, they read a script that said IUDs and implants, LARC methods, are the most effective methods of contraception, far more effective than other methods. We told them that up front, and then we introduced them to all methods. We did exactly what I said the nurse practitioner was telling the student, but I told you I'm against that now after the results of the CHOICE project. So we provided free contraception or no-cost contraception to all women in the project, and our goal was to reduce teen births, teen pregnancies, and repeat abortion procedures. Why repeat abortion procedures? We were specifically going to 2 centers that were providing abortions in our region and recruiting women because they were highly motivated. And we thought we could have the greatest impact on women coming back for another procedure because we can't stop the first one. So we wanted to look at repeat abortion rates, and I'll show you those results. Our goal is really to promote the 3 LARC methods, the IUD, 2 IUDs, and the implant. We wanted to see if we could increase the acceptability of these methods in our population, and then to study satisfaction, continuation rates, and population outcomes with these methods. Before we started the study, we looked around at Sentinel clinics, clinics that you're involving in a Step Ahead project, similar clinics in St. Louis, and we looked to see how often were IUDs being used. 1 to 2%, maybe, in these clinics. This was in 2006. Our goal was to increase that to 6% or more. The rates of post-abortal IUD use, I already told you, we didn't do it at all. It was 0. We wanted to increase that to 10% or more. And we wanted to see subdermal implants, which just hit the market, to increase to 3% or more. So you can see these results, 6%, 10%, 3%, are not very big differences. We didn't expect to see huge differences, but we did. We also hypothesized that the continuation rates would be much higher with the LARC methods, and that we thought we would see about a 10% decrease in some of our population outcomes, our teen pregnancy or birth rates, and our repeat abortion procedures. We postulated or hypothesized a relatively small reduction. 10,000 women we wanted to recruit over 4 years. That's a pretty large number. I've never done a study of that magnitude before. And it was interesting because I've never recruited for a clinical research study on time, ever. And this study was easy to recruit patients. Easy because the word of mouth traveled. Anytime I see a patient in the Choice Project, I would ask, how did you hear about the project? I heard from my mother, I heard from my sister, my cousin, my friend. The word spread like wildfire. It was great. Plus, giving out free contraception for 2 to 3 years is a wonderful benefit for a lot of people that need it. And people were just coming in. I had one mother bring in 3 of her daughters. One was 14, hadn't started being sexually active and hadn't even thought about being sexually active. She didn't get a method that day. So that was part of our inclusion criteria. I'll tell you about that. Every woman was provided no-cost contraception, and we followed them with phone interviews for 2 to 3 years. For folks that aren't familiar with St. Louis, we're right on the border between Missouri and Illinois. The 2 abortion clinics, one was here in St. Louis, one was actually across the river in Illinois. We went to both those clinics to recruit, and then we had other clinics where these stars are to recruit women. We focused in North St. Louis because that's the highest rates of chlamydia and gonorrhea and the highest rates of unintended pregnancy. Any woman of reproductive age, we started 18 to 45, but mothers and dads were bringing in their young women and asked if they could get methods too, so we went down to 14. They had to reside in St. Louis City or County. They had to be sexually active with a male partner, or soon to be, not desiring pregnancy in the next 12 months, desiring reversible contraception, not a sterilization, and willing to try a new method. That's the catch. We didn't want to compare a woman who's been on the pill for 4 years and happy with a brand new implant user. That wouldn't be a fair comparison. So they had to try a new method. They could go from the pill to the ring, the pill to the patch. They had to try a new method. So that was one of the inclusion criteria. This is roughly a scatter plot of where women came from. When we first started, we were recruiting outside St. Louis City and County. We were taking anyone who came to the project. Then we limited it to St. Louis City and County. And we did that because to measure population outcomes, we had to limit it geographically. So here's some of our data. We recruited 9,256 women. About 17% were from abortion clinics, 8% from community clinics. About 70% came from our university clinic or were referred in from private physicians or health clinics or student health or wherever. And we started in 2007, and we recruited and reached our goal within about 4.5 years. Really, 50 patients every week, 200 patients a month. It was like clockwork. They just kept coming. It was really hard to keep up with the demand. In fact, my project director begged me not to put more ads out, not to put it on the bus, not to put it on the metro line, the train line, because it was very hard to keep up with the demand. So we followed women every 6 months. After the first 3 months, we'd make a phone call, verify where we could reach them, then every 6 months for as long as they're in the project. We have very good follow-up rates. We followed women through 3 years. The first 5,000 women were followed for 3 years. The next 5,000 or 4,000 were followed for 24 months, but very high follow-up rates. So we have pretty good data. We didn't have patients come in. We just made a phone call, asked them how they're doing, asked a series of questions, whether they're happy with their method, whether they want to switch method, and followed them for pregnancies. We had a very diverse population. We had the poorest women from North St. Louis, and we had WashU graduate students and affluent women whose insurance just wouldn't cover their method of contraception. As you know, women who can have insurance coverage, but if they work for a St. Mary's Health Center or a religious-based affiliate, they won't have coverage perhaps for their contraceptive method. So they came to choice. So we had roughly 2/3 of our population were young. You can see here 14 to 17, 18 to 20, and 21 to 25. About 2/3 of our population, 60%, were less than 25. About half were African American, about a quarter out of high school or less, so quite a varied, diverse population. Here's our age again distribution. You can see we had 2,000 teenage girls. 2,000 teenage girls. Again, 50% African American, about 7 to 8% other racial groups. And in fact, the population was high risk from a socioeconomic point of view. About 40% had trouble meeting basic needs, trouble paying for their rent, trouble paying for utilities or food, and about 40% were uninsured. So a high-risk group. You can see here the most remarkable statistic from this slide is this one. 60% had had a previous unintended pregnancy. Now, I will tell you it's a bias because we recruited from abortion clinics, which every woman there, for the most part, most women had an unintended pregnancy. So that is a very high-risk factor for a future unintended pregnancy. So it's interesting, when you see our results of our unintended pregnancies, critics have said, oh, you have a low-risk group. They're all coming in for contraception. And we would say, no way. We have a very high-risk group. This is a very high rate of unintended pregnancies before coming in the project. 40% had a history of STDs, 40% had a history of a previous abortion. So when you make contraception no cost and you tell women LARC methods are the most effective, what do you see? In our project, 3 out of 4 women chose a LARC method. And that was pretty remarkable. We never expected that. In fact, I didn't budget for it. When the device costs like $700 and you don't budget, if you think it's going to be 10% and it ends up being 75%, you know what happens? You're in big trouble, okay? I had to go back to our funder and say, you want the good news or the bad news? Good news, we're really successful. Bad news, all that money you gave us, we need more. And they were very committed to us, which was wonderful. So you can see here, our most popular method was the hormonal IUD, followed by the copper IUD, implant about 17%, 7% depot shot, about 10% pill users, 7% ring users, and we had all types of contraceptive methods. We had diaphragm users. We had natural family planning, believe it or not. Not a lot. That wasn't our goal, but we had it in our project. What about young women? You can see here, we broke the young women, the adolescents, into 2 separate age groups, 14 to 17, 18 to 20. And we see an interesting shift. In the young adolescents, the implant is more popular than the IUD. Around 18, we see the shift where the IUD becomes more popular. And again, it's entirely up to them. We inform them of all methods, but this was an interesting trend that we saw. Still, over 70% of our adolescents were using and accepting a LARC method. So we wanted to look at short-term outcomes. Are they happy with their method? Are they satisfied? We wanted to look at long-term outcomes, such as the population-based outcomes, and let's see what we found. In terms of continuation rates, this is 1-year continuation rates of the LARC methods. Here's the Mirena copper IUD implant, over 80%. As a group, in 1 year, 86% were still using their methods. Insurance companies sometimes would say, we don't want to pay for these methods because too many women get them taken out quickly. It's not right. This is data to prove that. 85% or more are still using them at a year. Contrast that with depot shot, pills, patch, ring, around 50%. It's a big difference. 86% compared to 55%. That's continuation at 1 year. So this is just a measure of continuation and satisfaction. If we use the pills, birth control pills, which is the most common reversible method used in the US, use that as a comparison group, women using these methods, the LARC methods, have higher continuation, any number above 1 is higher, and higher satisfaction rates, while these methods are very similar. Lower satisfaction and continuation with the patch, but very similar among the non-LARC methods. So the point is, women not only accept these at a high rate, they're happier with them, and they continue them better. Adolescents, if properly selected, are appropriate for LARC methods, and again, consistent and correct condom use should be emphasized. What about continuation rates in young women? What about teenagers? Do we see any difference there? You can see here, here's our one-year continuation rates. They're slightly lower than the older women, but they're still very good for the LARC methods. Over 80% of teenagers were still using the LARC method at a year. And you can see these numbers are now consistently below 50%. So that means every woman you start, especially a young woman, on the pill, patch, or ring, by 1 year, they've stopped it. And you know what happens then. So below 50% for the non-LARC methods. And here, this is continuation in adolescents compared to older women. And you can see these are the three age groups. And you can see there's some subtle differences here. But really, the difference is between these groups of LARC methods and these non-LARC methods. Any LARC method, very high continuation. Non-LARC, low continuation in almost all age groups. So now I'm going to focus on the population outcomes. What did we see in the population when we provided these methods for free? And I'll focus on abortion, repeat abortion, and a couple other of the population outcomes. Reproductive Health Service is the main abortion facility in our region. And at that facility, it's affiliated with Planned Parenthood. They get women from a tri-state area, and of course they get women from St. Louis City and County. So we tried to see if there's any difference between people from St. Louis City and County and from other areas over time. Keep in mind, we started the project here. What you can see here is women from other areas, their rates or the number of abortions stayed roughly the same. But women in St. Louis City and County, we saw a pretty remarkable decrease. Now, I think I told you that we really wanted to measure repeat abortion. So this is the percent of women who had a repeat abortion procedure. And 2007, we started our project. We compared St. Louis in red to every other area in Missouri other than the cities and Kansas City. So we had a control group that's non-metro Missouri, Kansas City, and St. Louis. And over time, you see how the curves start to diverge. We looked at this in 2009. We put some statistics on it. We saw the statistic was less than 0.05, which is statistically significant, but we didn't believe it. Wait another year, we said. This is what happened the next year. So as you can see, our data, we're 2013 now, but the data lags well behind to put all this together on these cities and counties. So you can see the curves went even further apart. We see that the statistics are now statistically significant for two years in a row, so we're reducing abortion numbers and repeat abortion numbers. Barnes-Jewish Hospital does the greatest percentage of teen births in our region. This is a 17% decline over time in teen births at Barnes-Jewish Hospital compared to about a 7% decline nationally. Now then we started looking at what are the statistics specifically of our choice cohort, of our women in the choice project. We looked at the abortion rate of women in the choice project, and it was between 4 and 8 per thousand. Here you see the national rate of 20 per thousand. And you could say, well, you really can't compare them. And I would say you really can for a number of reasons. One is our group is higher risk. They're younger, they're lower socioeconomic status, and many have had a previous unintended pregnancy. Yet our rates of abortion were much lower than the national rates. Unintended pregnancy rate, as you heard in the graphic video, much lower than the national rates, 35 compared to 52. Big differences. Now we then looked at how were our numbers compared to our region. And you can see here the rate of abortion rate in choice between 4 and 8 compared to St. Louis City and County. And then we calculated how many abortions we've prevented. Thousands of abortions we've prevented. So we're preventing unintended pregnancy. The last column here is number needed to treat. What that means is this is the number of women you need to bring in the project to prevent one abortion. And that number, whether it's 80 or 140, is a relatively low number. Provide no-cost contraception to this many women, regardless of what they choose, and you'll see a reduction in abortion numbers. Here is annual rates of pregnancy, birth, and abortion among choice participants compared to a national statistic called the National Survey of Family Growth. Our numbers of pregnancy in teens, birth in teens, and abortions is a huge difference compared to national data. It's about an 80% reduction. Now, some people, skeptics, will say, how could this be true? And to me, it's absolutely obvious. If you have 75% of young women using the most effective methods of contraception with less than a 1% failure rate and a continuation rate of 85%, it's like a no-brainer. To me, it's what you would expect to see. Now, this was a project we looked at. We knew that long-acting methods were better than other methods, but we didn't ever, I don't think there's ever been a large group cohort study, a large group of women in the US that compared them. So we looked at unintended pregnancy rates within the CHOICE project. We had over 600 pregnancies in the CHOICE project. Some actually were intended. Some women stopped their method because they wanted to conceive. We had about 460 unintended pregnancies, and we looked at pills, patch, and ring in years 1, 2, and 3, and compared them to long-acting methods. We also compared them to Depo, and I'm leaving that out of the discussion a little bit because we only included women that came back for their shot. And guess what? Depo works really well when they come back. The problem is, in the first year, 50% don't come back. So long-acting methods, the results were incredible in terms of the difference, more than a 20-fold difference. And this is why we say we should use long-acting methods as our first line. They're 20-fold better than shorter-acting methods, and it's a big deal. It's a big deal in terms of prevention, and especially in young women. If you look, this is just stratified by age. Long-acting methods, age over 21, under 21, there's no difference here, but there's a two-fold difference when we look at pills, patch, and ring. The failure rate is two-fold higher in younger women using pills, patch, and ring than older women. And we already know the failure rate, if you go back here, is fairly significant. This is 4 to 5% after 1 year, up to 9 to 10% after 3 years with pills, patch, and ring, and a two-fold increase if they're young. So, family planning, including LARC methods, are the most cost-effective methods available and can prevent unintended pregnancies and save healthcare dollars. The Institute of Medicine said that to prevent unintended pregnancy is a major emphasis we should have in the US to save money and to improve women's lives. So we know family planning saves dollars. $1 invested in family planning saves $4 down the road. For LARC methods, it's more like $10 to $20. $1 invested saves more money down the road. We think no-cost contraception projects like A Step Ahead and CHOICE can really impact public health by reducing unintended pregnancies and individual benefits, of course, to patients who can then complete their schooling, finish their careers, and achieve what they want to in life. So back to our bottom line messages, and then I'll open it up for questions. LARC methods are by far the most effective methods. They should be first-line contraceptive methods for all women, not dependent on compliance or adherence. They should be free. They should be at no cost. People keep correcting me. It's not free. Someone's paying for them, that's true, but they should be no cost to the patient, and I believe strongly in that. I think there's important policy implications, too. I think that in terms of healthcare dollars and how we spend our money in the U.S., and we know we spend too much on healthcare, but this is cost savings. So to me, this is something we have to do in the U.S., and that's provide no-cost contraception. So I'll stop there. I'll tell you my 17-year-old is on a long-acting method, and I hope she's on it for a long time. My 15-year-old is still playing soccer, violin, and golf, and doesn't seem very interested in boys yet, but you know what I'm going to say when she gets to that age. So thank you very much. It's been a pleasure to be here. I'll be happy to take any questions.
Any questions?
Yes, sir.
I'd like to hear what you say to workers who are IUD, especially if you listen to the discussion.
Nullipers? Nullipers. So that's, many of the teenagers have come in. What is the discussion? So it's the same discussion we have for all women, in that we start with the long-acting methods. If you look at the Choice website, you'll see we have a number of publications, and one of our first ones provides our script for what we say to young women and to all women. And we start with, these are the two most effective methods, the IUDs and the implants. And we tell them how effective they are, and then we briefly describe them and talk about all other methods. But I think especially for young women, long-acting methods should be emphasized. And then we find out, in the Choice Project at least, if women came in with a strong desire for whatever method they want, that's what they got. There's no point in coercing women, making them take a method they're not going to be happy with. They're only going to stop it. But most women, let me ask you, if you polled women and asked them what is the most important factor when choosing a contraceptive method, what would it be? The most important factor. Effectiveness. That's what they told us. We did the survey, and that's what they said. What's most effective? So it seems like if you remove the cost barriers, people will go to the long-acting methods. Is that what you meant?
Well, specifically, I was talking
Nullips.
about IUD.
And in Nullips, we would do the same thing. I put one in just the other day with a brand new intern in a 17-year-old Nullip, and people would say, how can you do that? Their cervix is closed, and it's going to cause a lot of pain. You'd be amazed. Most of the time, it's a very easy insertion. And there's techniques you can use that I'm happy to go over with you. One is you have to talk them through. You have to walk them through what's going to happen. Sometimes it could even be their first pelvic exam. Now, the IUD may not be right for all women in that situation, but gentle, caring approach, gentle speculum exam. I always use a little lidocaine before I put the tenaculum on. We use very small sounds at first to go into the cervical os. We sometimes use an os finder, which has a graded tip, so we can open up the cervical os a little bit. We tell them they're going to feel some cramping. We may use a paracervical block if they're very uncomfortable. Our habit is to always use some ibuprofen ahead of time. It may not help for the procedure, but we think it helps after the procedure. And I would say 90–95% of the time, Nullips, young women, we put the IUD in. And I'll tell you, in Choice, almost all of them were put in by nurse practitioners. Okay? Doctors can do it too, but I'm just telling you, we all can learn to do it, and we can do it in young nulliparous women. Do you have failures? Yes. You can use a little misoprostol. You can use some small cervical dilators. Those kind of things are tricks that are helpful. Yes, sir?
Mrs. Howard, what has been the biggest barrier to enrolling or active places? There's one less step ahead or before.
One of the questions I was asking, one of the fears that women have is that it's Thank you. The question is, what are the barriers that a step ahead is facing? And we see in the female population, many times women are afraid. And so it is this fear of it hurting that we're concerned about. But the main thing is really getting it in the community. And it's because in community clinics, having a method that even in a 340B clinic costs $300, having it sitting on the shelf waiting is something that economically they're not able to do. And I perfectly understand that, but nevertheless, it's very important to have the methods on the shelf and waiting when the woman comes in. And when she comes in and she's ready and willing to have it, she needs to get it right then. And waiting and having her come back, because you don't have it on the shelf, or because you've got to wait till your doctor who's trained up comes in, that's one of the really critical barriers. Having clinics that all have the Nexplanon ready to go, that's a real barrier. And then for the women, you know, they're all concerned it will hurt. But if you have a clinician who is trained to say, oh, you know, honey, this isn't going to hurt, come on, you're going to be fine, then, you know, that's what makes a big difference. Did I answer that?
So you may not be able to do same-day insertions and a step ahead right away. But the goal is that we should all strive for that. I think that was our idea with this icon, kind of crazy idea, is that we think that women should be able to walk in and get their method that day. I mean, like you want your iPhone, you want your computer, you go and you get it. I mean, why should you go in, people talk to you? If you know that's what you want or you've been counseled appropriately, why not get it that day? Most women should be able to do that. You may not be able to make that big leap at first and a step ahead. It's a good question. You know, I knew I was going to be asked that question, and I've asked a number of my colleagues how they feel about the new IUD. And I'm still trying to figure out where it belongs. Even the reps for the company will tell you that it shouldn't replace the Mirena. It's a lower level of hormone. It lasts 3 years. It's smaller. The inserter is smaller. And so maybe there'll be 14, 15, 16-year-olds where you've struggled to put the IUD in and you want to use a smaller inserter, or a young woman you want to use it for dysfunctional bleeding. But I don't have a big role for that IUD quite yet. Why? Because I think a Mirena is just fine in a 17-year-old. I don't have a problem with that. So I'm not looking for a millimeter or less inserter that goes in. I don't have a big role for it yet. Yes, ma'am?
For parental consent issues that you have to deal with your minors, or how does that work?
Yeah, so the question is about parental consent issues. Now, that is state dependent, and maybe someone here can tell me but how it is in Tennessee. But in Missouri, basically for family planning, we don't need parental consent. Is that the same here? Same here. So the difference in choice is that research is a little different. So because we're doing research on a 15-year-old, we wanted to get parental consent. It was very rare that we didn't. Now, we had to get a special federal exemption and all this, but almost all of our teenagers, we had parental consent. And most parents want their kids to have birth control if they have a hint that they're sexually active. Yes, ma'am?
Have you ever found the litigation advertising about IUD that people see on day-to-day?
What a great question. And it's just nothing makes my blood pressure boil than these litigation questions that we get on TV. What do you do? What do we do about those litigation questions or the litigation advertisements on TV? And I was at home when it came on the television, and you know what I decided to do? I decided to call the law firm. I just decided to call them up and tell them, my daughter has an IUD, and I want to find out what this is about. Well, I got to run around. I had to go through 6 different paths. What a waste of time that was. But what are we doing about it? I think we need to fight back. One is we developed a script so that when women, and we have thousands of women using an IUD, call our project and say, my mother just told me I got to get the IUD out. There's something on the TV that says they're harmful. We had a script that tells them, here are the risks. It's at very low risk, and you have to keep that in perspective. Because what people don't realize is that we have risks in everyday life. Just like with the birth control and the fear of thromboembolic events, pregnancy is so much greater of a risk. The risks of pregnancy, thromboembolic events, and all the other things of death, all those are much greater in a pregnancy. So we have to put it in perspective. And actually, we've talked to ACOG, we're talking to the companies. I think we need a counterattack. I think we need commercials that appear right after that law firm that say, the commercial you heard, and you can say whatever you want, but it's completely untrue, and here are the real risks. So I think we need a counterattack, actually. So I'm not sure what's going to happen. I think ACOG is aware, but I can't stand those ads. Other questions?
Thank you.
Well, great. Thank you very much.
Thank you.
My pleasure.
2 things. First is, everyone turn in a blue form, please. And if you want credit, you turn in the green form. So there's a blue form and there's a green form. And we want all of your information on the blue form, but the green form is for the credit. And also, Dr. Piper, thank you very much. We have a special book for you on the medical community in Memphis. We are hopeful that you'll be with us to help write the next chapter of it. And we hope the next chapter will include how we've changed the lives of women in Memphis by offering them access to these methods.
Wonderful. Thank you. And good luck with a step ahead. I think it's a wonderful project.